Hello everyone, welcome to PNS 1204 Pediatric section. We're going to start off with chapter 14, which is the physiological and behavioral adaptations of a newborn. My name is Dr. Sanity and I'll be your instructor for the remainder of the course. Okay, so let's start. Before we do anything else and go through the chapter, we're going to learn about some conceptual phrases that we need to know. The most important one, especially for newborns and infants, is thermoregulation. What is thermoregulation? Thermoregulation is basically the body's ability to maintain the temperature or the body temperature at a certain level. All people of all ages are susceptible to issues and complications with thermoregulations, but in newborns and infants, specifically babies who are premature or underweight as well, um, are at a higher risk for hypothermia for several reasons. One is because of their large surface area to body mass ratio, and then their lack of subcutaneous fat, and issues with temperature regulation. So all of these can put the infant at risk for hypothermia. Now, the fetal lungs develop and mature during the last trimester of pregnancy to support gas exchange at birth. Surfactant, which is a mixture of phospholipids and lipoproteins, is produced in the fetal lung cells. The production of surfactant begins around 24 weeks of gestation, with distribution through the lungs starting at 28 to 32-week gestation. Sufficient concentrations to prevent respiratory complications occur at around 34 to 35 weeks of gestation. It's important for newborns because it prevents the alveoli from sticking together when the newborn takes its first breaths and makes it easier for gas exchange to occur in the lungs. Brown fat, which is a body fat that is used by infants to regulate body temperature, um, is really important for newborns and infants because that's what they use to regulate their body temperature. An infant does not shiver to raise the body temperature, they burn brown fat instead. So, in adults, when you get really cold, your body starts to shiver. That's your body's mechanism of trying to increase the heat, the core temperature of your body, and warm you up. Infants don't have that mechanism, so their bodies will start burning the brown fat. The main function of brown fat is to protect the infant from hypothermia. It is deposited during the last few weeks of gestation. Brown fat is located in the scapular area, the thorax, and behind the kidneys. And this is why sometimes you'll get really young kids, and they're 1 or 2 years old, 2-year-old kids, who will run outside in the cold. Um, and you're like, wear your coat, you're going to catch a cold, you're going to get cold. And they're running around, they're perfectly fine, or they sweat a lot during night times. It's because their body is burning that brown fat and increasing their body temperature. In infants, glucose is stored in the liver as glycogen to provide an energy source for the newborn at birth. During labor, the fetal adrenal glands are stimulated to produce catecholamines, which are the hormones dopamine, norepinephrine, and epinephrine. These hormones increase the level of surfactant in the fetal lungs. Again, to help them with the breathing, they increase blood flow to the heart, lungs, and brain. They increase energy and stimulate white blood cell production in the immune system. So, immediately after birth is a very significant time physiologically for the baby as it starts to adapt to the extrauterine life. It is very, very important to be able to assess and determine if the infant is healthy or if the infant requires any assistance for this transition to extrauterine life. For example, was the infant was the infant born premature? Did the infant have a non-reassuring fetal heart rate while in labor? Does the infant have shoulder dystocia? And several other factors that need to be determined. This is why the prenatal visits and the OBGYN visits during labor are really important for us to determine if the infant needs assistance in transitioning to extrauterine life so we can have necessary supplies and personnel on hand at the time of birth. Okay, so as we mentioned, thermoregulation is really important for the infants and newborns because their body does tend to lose heat pretty quickly. And there are four different ways an infant can lose heat through evaporation, convection, and radiation. So evaporation is when, for example, when the baby is born and they're covered in amniotic fluid and you dry them off as while that amniotic fluid is evaporating, it pulls heat from the core temperature of the baby's body and drops the baby's temperature. Conduction is if you put the baby's skin in contact with a cold temperature, with a cold surface, that will cause the infant's body temperature to cool down. Transfer of the infant's body heat to surrounding cold air is convection, which is like surface to air transfer. And then radiation is when the heat transfers from the body to a nearby surface. So the baby isn't in contact with it, but it's right next to the baby. It's cold, so it will pull heat from the baby's body. Now, it can take up to 4 hours for a newborn's temperature to stabilize, so it's very important to monitor the baby's temperature in those 4 hours. Infants don't have subcutaneous fat to provide insulation, and their body vessels are very close to the surface. They only have that brown fat reserves that we talked about, so their body will start burning those to kind of make up for the heat. The preterm babies, you need to keep in mind that if the baby is like extremely preterm or um, small or in weight size, then they will have either very small or no brown fat reserve to assist with thermoregulation. Um, so when the brown fat is burning on infants that have brown fat, when the brown fat reserves are burning, they can burn real quick and be quickly depleted because the body's trying to pull up that temperature as fast as possible. So we have to make sure the baby's not experiencing prolonged cold stress periods. Because if this does happen, what happens is the brown fat breaks down into fatty acids, which can lead to metabolic acidosis in the newborn, which is an extremely dangerous situation. So as we mentioned, infants don't have that shivering mechanisms that adults do to raise their body temperature, but what they will do sometimes they'll start to kick or cry and kind of like move their body around to try and raise their body temperature. What happens is they're so small that they get real fatigued really quick. Also, what you need to pay attention to, that thermal regulation increases uh, the metabolism in the infant, and so what comes with uh, an increase in metabolism, what happens when you have real high metabolism? You have an increased need for oxygen. You're going to have a decrease in, with infants, a decrease in surfactant production. They'll have an increase in the use of stored glycogen, which can lead to hypoglycemia with for the baby. And then, as we mentioned, the rapid metabolism of the brown fat can also lead to metabolic acidosis. So, as nurses, what's important for us as nurses, what we need to be monitoring is for thermoregulation, includes drying the infant immediately after birth and removing all the wet towels. So you don't want to let the baby, any of the amniotic fluid on the baby's skin air dry. Place the baby skin to skin with the mom as soon as possible and cover him with a warm blanket so the baby can get some of that heat from the mom's body. Cover the head as soon as possible. Infants lose a lot of heat through their head. Monitor their temperature every 15 minutes for the first hour or follow facility protocol, facility policy. Avoid uncovering or exposing their entire body for procedures. So if you need to take a temperature or if you need to do anything with the baby, listen to their lungs or whatever, just expose the area that you need to access. Don't take the blanket completely off of them. And then if they can't, for any reason, maintain skin to skin contact with their parent, you can put them under a preheated warmer. That's why you'll always see in OB units when a mother goes into labor or they take a mom in for a C-section or whatever, they'll immediately pre-warm the warmers, the radiant warmers. And then don't bathe the baby or don't wash them until they have a stable temperature for at least 2 hours. And then, of course, this is obvious, but don't place the baby's crib or bassinet near a draft or window or somewhere cold. As we all know, fetal lungs are filled with amniotic fluid inside the womb. And the fetus receives oxygen through the umbilical cord from the placenta and the umbilical vein. The umbilical vein transports oxygenated blood to the fetal heart. Once the fetus is born or the infant is born, a sequence of events must happen in order for the infant to start breathing again. So the most important thing is we're going to go through the steps. So for breathing to occur, a sequence of events must happen, including internal and external stimuli. Internal stimuli are chemically focused. External stimuli are mechanical, sensory, thermal, changes in the newborn's body. Once the infant is born, the pressure changes. So when it's moved out of the uterus, out of the amniotic fluid, the pressure changes. This pressure uh, change squeezes the secretion of amniotic fluid out of the lungs. Once that happens, another pressure change occurs and causes the chest to recoil and causing the lungs to fill up with air. At this point, as we mentioned, surfactant increases to keep the alveoli open and to prevent them from sticking to each other. Cutting the umbilical cord causes the respiratory centers in the brain to begin working in response to the dropping blood pH. So basically, once you cause the umbilical cord, the brain notices that, hey, I'm not getting this oxygenated blood to the umbilical vein anymore. Better start breathing and filling the lungs up with oxygen. So nursing interventions for us is when the baby is born, we're going to count the respirations per minute, suction the mouth and nose so we're getting any of that extra amniotic fluid out of the way, monitor the infant's A newborn's blood volume is 80 to 110 ml per kilogram, and a newborn has more red blood cells than the average adult. These red blood cells provide extra oxygen for the stress of labor, and also a newborn's hemoglobin averages 17 to 18 grams per 100 ml of blood, and the hematocrit is between 45 to 50%. Do you need to memorize these numbers? No. But it's good for you to know because it gives you an idea of the volume and the comparisons to an adult's body. After the stress of labor has passed and oxygenation through the lungs is established, the large number of red blood cells is not needed by the newborn anymore. So within days, the extra red blood cells begin to break down. As they're broken down, bilirubin, the waste product of the red blood cells, is released, and the serum indirectly increases the bilirubin levels. That's when you get the jaundice baby. The normal term newborn also has an elevated white blood cell count range from 15,000 to 30,000. This doesn't necessarily mean that the newborn has an infection, but it does reflect how stressful just the act of birth is on the infant and on the infant's body. So newborns have diminished ability to clot blood because of the absence of vitamin K. We know that vitamin K is essential for the formation of factor 2 prothrombin and factor 7, factor 9, factor 10 in the clotting sequence. So in humans, vitamin K is synthesized by the bacteria in the intestines. A newborn, because they have sterile intestines and they have not consumed any milk or any food yet, they don't have any vitamin K. They don't have enough of that bacteria that can synthesize the vitamin K. So the synthesis of the vitamin K usually begins about 24 hours after birth and after the first feed. So the kidneys of a newborn are immature and they cannot concentrate urine well. So until the baby is about 6 weeks old, the urine of the newborn will be odorless and light in color or clear. You want that baby to void at least once within the first 24 hours of birth with a volume of about 15 mLs. So that's important. Void at least one time with a volume of at least 15 mLs. For the first 2 days of life, the total daily output should be about 30 to 60 mLs. So that's a huge contrast with the adult amount that we expect from an adult. Right, for an infant, for the first 2 days of life, 30 to 60 mLs is enough. And then as they start breastfeeding or formula, as they start feeding and taking in more fluids, that amount can rise to 250 or 300 mLs a day. So what does this mean for us as nurses and as LPNs when we're taking care of a newborn? You want to monitor the first void. We said the best way to measure the amount of output on an infant is, or on a newborn, is to weigh the diaper. So you're going to weigh the diaper. If you're concerned about the output, if you don't think it's enough, you're going to weigh the diaper. And how do you do that? You must have the weight of the diaper when it's dry, then you put it on the baby, and then you weigh it when it's wet. Now, um, you also want to encourage frequent breastfeedings to increase fluid intake, and we'll cover this more. Also, when you're encouraging more breastfeedings, you want to make sure that the baby is latching on correctly and has good swallow reflex. Now, the newborn's intestines are completely sterile at birth. Obviously, the baby's born, there's nothing in there, they're completely sterile. When the bacteria from the mom's milk enters the baby's body, it creates probiotics in the baby's intestines, and then those help in digestion, and they also help synthesize vitamin K. The newborn's stomach is really, really small, 60 to 90 ml. So we need to make sure that we are educating the parents about this, and we're letting them know, because the parents will be like, well, but baby only eats a little bit. It doesn't eat much. So we need to make sure we need to educate them that baby might not be eating much. They might need more frequent feeds because their stomachs are so small, they have such low capacity. And then we need to educate them that when they do overfeed the baby too much, that's when the baby does tend to um, vomit a lot and um, bring up a lot of the milk or the formula or breast milk, whatever it is. So what we need to do is after the birth, we need to monitor for meconium stool, which is the baby's first bowel movement or the first stool, and report it if it doesn't happen within the first 24 hours. So if the baby doesn't have any meconium stool within the first 24 hours, we're going to report that to the RN and the provider. We're going to help with teaching the parents not to overfeed the newborn, and we're going to help with teaching the parents about the immature cardiac sphincter and regurgitation, because the cardiac sphincter between the esophagus and the stomach is really weak, and that's what, especially if they overfeed the baby, that's what's going to cause regurgitation and vomiting. At birth, the infant's liver serves to store glycogen and iron. The infant's immature liver does not detoxify medication or break down bilirubin from red blood cells efficiently. So we mentioned that within days, because the infant's body doesn't need that high concentration of red blood cells, they start breaking down. The liver tries to break these down and tries to move those yellow pigmentations that are the result of the breakdown of red blood cells away and get them out of the body, but it can't do this efficiently. When it can't do this efficiently because the newborn's liver is immature, the number of unneeded blood cells are too high, so the job of breaking these down and removing them is not accomplished effectively. This causes a large number of babies to develop what we call jaundice by day 2 or 4, which is a normal physiological response. Nursing interventions are you're going to monitor for yellow sclera, yellowing of the skin, and reporting these findings. And then some parents kind of get nervous about this or don't know what it is. You're going to help educate the parent and explain to them that this is a normal physiological response. That's the result of the breakdown of the red blood cells. The newborn's immune system is consistent of passive antibodies passed to the baby from the mother through the placenta. Now, if the mom is fully vaccinated and has had these illnesses or has had these illnesses, the newborn is protected from polio, measles, diphtheria, pertussis, chickenpox, rubella, and tetanus. This passive immunity from the mother protects the infant for the first 2 to 4 months of life. And then that's why newborns don't need to start producing their own antibodies until the age of 2 months. So when you're taking care of these little babies that just came out of a very, very sterile environment, you want to make sure that you're following the correct nursing interventions and precautions. You're going to maintain a very strict hand washing for everyone who's taking care of the newborn. Educate the family. Everybody, don't let people just come in. Educate the parents and the family. Not everybody should be in there kissing the baby. Do not kiss the baby's face. Don't let every single family member come in and kiss the newborn's face. Protect the newborn from infection. It's your job as LPNs and RNs, as LPNs, to help educate, assist in educating the family and the parents that they really need to be vigilant about protecting the newborn from infection, especially in the first 2 months. Screening healthcare personnel and visitors for illnesses. If you work on a OB unit or a maternity unit, you're taking care of newborns. If you feel sick, don't take care of babies. Call off, wear a mask, don't go into the newborn's room. It's not worth it. Teach the parents about hand hygiene for themselves, family members, and visitors, as we mentioned. And then it's completely up to the family and the parents what they want to do, but it's our job to educate them about immunizations and educate them about the benefits of immunizations and vaccines. So we're not going to impose our own beliefs or our own opinions on anybody, but we're just going to educate them about the science. Even though babies are nonverbal and they can't talk, they still give us a lot of cues on how they feel, and they have their own little extraordinary communication methods. So babies, their main way of communicating is crying. So if they are seeking attention for any reason, whether it's pain, discomfort, hunger, they're trying to seek attention, they're going to cry out to try to get your attention. When they're comfortable, they'll and soothed, they'll be quiet, and also when they're comfortable and feel safe, they will engage in mutual gazing or staring at a person and following them, tracking them with their eyes. And then usually if they like somebody, they'll track the person with their eyes. If they don't like them or don't care for them, they'll look away from them or turn away from them. You have to remember that each baby is different. Babies they're not toys, and they don't all act the same. It's not like a toy you buy and say, if you push this button, this should happen. So every baby is different. They have their own personalities. They have their own behaviors from the very start. So you need to educate the parents on this, and you need to make sure that they're aware about their baby's behaviors and cues, nonverbal cues. All healthy newborns go through expected periods of alertness and sleepiness. Their metabolisms are extremely high. Their bodies are going through a lot of changes, so they do run out of energy quickly. Their first period of reactivity occurs within the first 30 to 60 minutes immediately after being born. During this time, they're usually alert, active, cooperative. They're crying. They have vigorous sucking reflex. And that's why this first 30 to 60 minutes is the best time to try to give them that skin-to-skin contact with the mother and try to get the baby to latch on to the mother and get that sucking reflex going and assessed. And then after this brief period, they fall into a deep sleep because they're wore out from the birth, from the delivery. From their 30 to 60 minutes of activity, they're extremely wore out, so they're going to go into a very deep, almost non-responsive sleep for about 2 to 4 hours. And this is known as a period of relative inactivity. So they might not move, they might stay in one position and not move at all. And then during this time, the newborn is unresponsive to external stimuli. The heart rate and respiratory rate both decrease but stay within the normal limits. So we're going to monitor the baby very closely during this time. And the parents might have trouble waking the baby up for breastfeeding during this time. If that happens, you're going to educate them, tell them what's going on, tell them that the baby's in a very, very deep sleep, and they can wait a few minutes before waking the baby up and feeding it again. And then the second period of reactivity begins when the newborn wakes up from this long, deep sleep and is again alert, active, hungry. They'll probably start crying again because they'll be extremely hungry after those 2 to 4 hours of sleep. The heart rate and their breathing varies and depends on the external stimuli and what's going on. So make sure this short period of time you're educating the parents about what's going on and you're keeping an eye on the baby's vitals. Chapter 15: Nursing Care of the Newborn. Usually, the first person that's going to assess the baby and lay eyes and hands on the baby is the nurse, and the initial assessment that's done within the first minute of the child being born is called an APGAR score. So, what does APGAR stand for? It stands for appearance, pulse, grimace, activity, respiration. The APGAR score is a quick and easy way to assess a newborn's health immediately after birth. So, appearance is skin color, blue, pink, purple. Pulse, your heart rate, is it present, is it absent? Grimace, the reflex irritability of the baby, is the baby crying, grimacing, not moving? Activity, muscle tone, is the baby limp, is the baby active, are they moving all four extremities? And respirations, breathing effort, is it absent or present? Each category is assigned a scale score from 0, 1, or 2. So the higher the score, the better the health. So if the baby is born and the skin color is nice and pink and normal, or um, normal for the baby's ethnicity, then the baby gets a 2. If the baby is born and skin color is not very good, the baby is blue or purple, then they'll get a 0 or 1. The total score is added up for all 5 categories, and anything we want the baby to score anything above a 7. 7 or higher is normal. 4 or less needs immediate medical attention. So if the nurse assesses the baby the first APGAR and gets a score of 4 or less, we're going to notify the physician or notify the pediatrician and let them know the results of the APGAR score. Vital signs indicate physiological functioning and include heart rate, respiratory rate, temperature, and blood pressure. Blood pressure is not routinely assessed on a newborn unless there are suspicions of a congenital cardiac anomaly or abnormality. Hospital policies vary on timing for newborn vital signs, but they're usually taken every 30 minutes for the first 2 hours at birth, then every 3 hours, and then every 4 to 8 hours, so on and so forth. So just make sure you're always checking the hospital and facility policy to see what their policy is on how often vital signs need to be checked. So, this is really important. You really need to know your vital sign ranges for newborns. Your temperature for a newborn needs to be between 36.5 to 37.4 degrees Celsius. That would be 97.7 to 99.3 degree Fahrenheit auxiliary. And then your heart rate asleep, your sleep heart rate needs to be 100 beats per minute. Your wake heart rate is 120 to 160 beats per minute when the baby is awake. And when the baby is crying, your heart rate is going to be 180. Respiratory rates from the newborn will range anything between 30 and 60 breaths per minute. So if you're between that 30 to 60 breaths, you're good. Blood pressure, again, not routinely assessed, but your systolic needs to be 50 to 75, and your diastolic needs to be 30 to 45. The newborn skin assessment is going to tell us a lot about the baby's cardiac function, their respiratory function, their gestational age, and of course their thermal regulation, whether they're cold or hot or if they have appropriate temperature. So according to the baby's ethnicity and skin color, they're going to have different tones and different shades of skin. For the most part, you want to keep an eye or check the baby's mucosa or the mucous membranes. Make sure they're nice and pink. Make sure that the baby's skin is nice and pink. There's no blueness to it, or it's not purple. Some acrocyanosis is normal for the first 24 hours. Acrocyanosis is a bluish tint to the distal extremities, the hands and legs, the fingers and the toes, which will resolve itself after 24 to 48 hours when the baby breathes and the lungs work and that oxygenated blood circulates a little more. And then you have the lanugo, which is that fine downy hair that usually covers the baby's body. And then when the baby's born, you have that vernix caseosa, which is that white protective coating on the skin. So you're going to assess all of those when you're doing your skin assessment on the baby. In the skin assessment, you might also notice some birthmarks, rashes, or skin lesions. There's different kinds of birthmarks. You can read through them on the slides. I'm not going to read every single one by one, but what you need to keep an eye on, you need to know what every single one of those are. So if you need to know what a hemangioma or strawberry hemangioma is, you need to know what a erythematoxicum neonatum is. So what you need to keep an eye on as an LPN, as a nurse, is reporting abnormal skin assessment findings. So the main abnormal skin assessment finding is we said cyanosis. So if the patient or the baby has marked cyanosis on the skin, which could be caused by cardiovascular or respiratory problems. If the baby has thin skin with abundant lanugo, which could indicate prematurity. If the baby has meconium staining, which may be caused by hypoxia in the uterus. Poor skin turgor, which may be because of dehydration. Paleness or pallor, which could be because of anemia or hypothermia. And any abnormal or concerning mole or other kind of skin abnormality that you notice on the skin that you don't feel comfortable with, you need to chart and report to the healthcare provider. Moving on with the newborn assessment, we're going to go over to the newborn head assessment. So when you're assessing the baby's head, you're going to assess the shape of the head, the circumference, any appearance, any suture lines, all of that stuff. So another condition that may be noticed on the head is cephalohematoma, which is swelling on the head that does not cross the suture lines. It is caused by birth trauma that causes a rupture of blood vessels between the skull and periosteum. It usually appears by day 2 of life and may worsen over a few days. The cephalohematoma will generally resolve itself over days or weeks as the blood is reabsorbed by the body. Caput succedaneum is a swelling of the scalp of the newborn. It's caused by pressure from the uterus or vaginal wall during delivery. The scalp will be soft and sponge-like with possible bruising. Caput succedaneum uh, is superficial and does cross the suture lines, no treatment is needed. The swelling will resolve itself and decrease over a few days. The next assessment is going to be your eyes, ears, and nose assessment. So the main thing you're looking for is for any anatomical abnormality. So the initial thing that you're going to look for is any anatomical abnormality that you can see with your eyes. Like, is the baby missing an ear? Is the baby's nose crooked? Is the eye, one of the eyelids um, misformed or misshaped? What's going on? So any physical abnormality that you see is the first thing that you're going to report. And then you're going to document and report yellow or red sclera in the eyes, any exudate or discharge noticed from the eyes, from the nose, from the ears, any drooping of the eyelids, any lack of response from the newborn to loud noises, which could allude to maybe possible hearing complications, any obstructed nasal passages physically, maybe if the baby has any kind of polyps or growths or anything in the nasal passages that could be obstructing it. Any anatomical abnormalities like we mentioned in the eyes, ears, or nose, and any nasal flarings. For the mouth, similar to the eyes, ears, and nose, you're going to inspect the lip, the mouth, the tongue, the palate, and the gums for any anatomical abnormalities. You're going to assess for asymmetrical movement of the lips or the tongue. Mucous membranes should be nice and pink. If they're not, if they're pale, if they're dark, anything like that, you're going to report that. You're going to report any excessive bubbly saliva, an absence of a sucking reflex. If there's a hole in the palate, you're going to report it. In your chest assessment, you're going to observe for shape and symmetry of movement. In male infants, you could see some gynecomastia or breast enlargement from maternal hormones. You can report that. Any variation in chest size from the norm, either too large or too small, is something that you're going to report. Any abnormalities in the placement of the size of the nipples, and any purulent or bloody discharge from the nipples, you're going to report. Infants with respiratory distress may exhibit seesaw movements of the chest and abdomen, nasal flaring, and retractions. Retractions are pulling of the skin around the ribcage and sternum when inhaling. When inhaling becomes hard work for the infant. When auscultating the newborn's lung fields, use a pediatric or a newborn stethoscope. Do not use a full adult-sized stethoscope. The smaller size, 2.5 centimeter diameter diaphragm of the pediatric or newborn stethoscope makes it easier to hear the lungs without hearing other body sounds at the same time. Listening to one lung field and cross over to the opposite side to compare the two lung fields. The normal newborn will have wet sounds such as crackles for the first 24 hours after birth because of the long immersion in amniotic fluid during gestation and lungs haven't been filled with amniotic fluid. You're going to document and report any of the following findings that you notice. Notice a respiratory rate of less than 30 or more than 60. So this is something that you're going to document as abnormal. Cessation of breathing or apnea of more than 20 seconds. Any normal sound other than crackles in the first 24 hours. Any increased work of breathing noticed, especially seesaw chest movements and retractions of skin around the ribs and the sternum. So any of these, you're going to chart it and report it to the provider or the nurse. For your cardiovascular assessment, you're going to listen to the heart, to the heart sounds, um, and you're going to assess your peripheral pulses for equality and quality. You're going to assess your cap refills, and you're going to document any abnormal cardiovascular assessment findings, such as a heart rate below 110 beats per minute or above 160 beats at rest, any heart sound other than the normal S1 and S2, any abnormal heart sounds such as blowing, clicking, or mechanical sounds which could indicate a murmur, any discrepancy between the peripheral pulses side to side and with the apical heart rate. And then for your abdominal or gastrointestinal assessment, you're going to observe the shape and contour and movement, assess for bowel sounds, stool, and you're going to assess for abnormal findings such as, or document abnormal and report abnormal findings such as failure to pass meconium stool within 24 hours, a closed anus. Some babies are born, some infants are born with without an open anus. If that's the case, if you notice that, you need to report it immediately because it can be fixed surgically. An absence of any kind of bowel sounds after 2 hours, or a completely flat abdomen in a newborn infant. When assessing the heart sounds, first focus on identifying S1, which is the closure of the mitral and tricuspid valves, and S2, which is the closure of the aortic and pulmonic valves. Next, after you've identified S1 and S2, next notice the regularity or irregularity of the rhythm. And then finally, systematically listen to the different heart areas using following sequence. The aortic valve area by placing, so first you're going to listen to the aortic valve area by placing the stethoscope at the second intercostal space at the right of the sternum. So number 1 in the picture. 2, the pulmonic valve area by placing the stethoscope at the second intercostal space to the left of the sternum. 3, the tricuspid valve area by tricuspid valve area by placing the stethoscope at the fifth intercostal space at the left of the sternum. And 4, the mitral valve area by placing the stethoscope at the fourth intercostal space at the left of the midclavicular line. Just as in adults, the best way to remember these 1, 2, 3, and 4 is all physicians take money, APTM, aortic, pulmonic, tricuspid, and mitral. In the genitourinary system assessment, you're going to inspect for ambiguous genitalia, also known as atypical genitalia or disorder of the sex development, which is a rare condition where the external genitalia do not clearly appear male or female. This can be caused by a variety of factors, including chromosomal abnormalities, hormonal imbalances during fetal development, and imbalance in hormones like testosterone or estrogen can lead to ambiguous genitalia, genetic mutations. And then you're also going to inspect the female genitalia for placement of labia and urinary meatus. You might see some pseudomenstruation in female infants, which is mucus and blood-tinged vaginal discharge. It's not a real menstruation. And you're going to inspect the male patient's penis for a midline and straight urethral opening. If the urethral opening is not normal in the male or the female patient, you're going to chart and report that. And then you're also going to assess the urinary output. For the neurological assessments in your book, if you go to table 1512, 15.12 on page 256, 257, depending on whether you're looking at the hard copy or the electronic book, you'll see a table that lists all of the reflexes and the age that the reflex disappears at. So you have the Babinski reflex, the plantar grasp. You can go and look all these up on the table. Make sure you read all of this. This table is very important. You will have questions from this table on tests. The rooting reflex, gag reflex, Morrow, the palmar grasp, stepping reflex. These are all things that are checked on a newborn infant. On a newborn infant, jerking, twitching is normal, and then you're going to chart any abnormal neurological assessments. You also have the Barlow and Ortolani maneuvers, which are physical examination techniques that are usually done by the pediatrician that are used to screen for developmental dysplasia of the hip, a condition where the baby's hip joint is not properly formed. The Barlow maneuver, the examiner moves the leg inward or adducts the leg and extends the baby's knee. Gentle posterior pressure is applied to the back of the knee. A positive Barlow maneuver occurs when the hip dislocates, producing a clicking or popping sensation. Ortolani maneuver, the examiner abducts, moves the leg outward, and flexes or bends the baby's knee. Gentle anterior pressure is applied to the front of the thigh. A positive Ortolani maneuver occurs when dislocated hip is reduced back into the socket, producing a clicking or popping sensation. A positive Barlow or Ortolani maneuver suggests that the hip may be dislocatable. Additional tests such as ultrasound may be necessary to confirm the diagnosis. Early detection and treatment of these conditions are important to prevent long-term complications such as arthritis and limping. These maneuvers are typically performed in newborns and infants up to 6 months of age. They should be performed by a healthcare professional with experience in musculoskeletal examinations. A positive result does not always indicate a problem, and further evaluation is usually needed. One of the reflexes that is in the table, and you've all probably seen done by physicians, is called the Morrow reflex. It's also known as the startle reflex. It's a reflex that can be tested in babies and adults to assess their nervous system. A healthcare provider will test the baby's Morrow reflex shortly after birth and during a well child visit to test the baby. To perform the test, the baby is placed face up on a soft surface, and the provider gently lifts the baby's head, supporting it enough to remove some of its body weight from the surface, and then they suddenly release the head, allowing the baby to fall back slightly, and then quickly support the head again before it hits the surface. A normal response in the baby is that the baby will look startled. They'll extend their arms and legs and palms facing up and thumbs flexed. They'll cry for a short time. They'll bring their arms back into their body, flex their elbows, and relax when their head is supported again. This reflex usually disappears around 6 months of age. For your musculoskeletal system assessment, you're going to assess for any abnormalities, any form of musculoskeletal abnormalities, any missing digits, any curvature in the spine, any asymmetry in the spine, anything that looks abnormal in the extremities, in the hands, and the legs, the feet, the ankles, the joints, the elbows, everything. And then for the infant pain assessment, we usually use what's called a NIPS pain assessment, an NIPS, which is a neonatal infant pain scale. If you go to your book on page 259, table 15.3, you'll see the NIPS table there, and it'll show you. So if the baby has a relaxed facial expression, they get a 0. If it's contracted, they get a 1. And then you walk your way down the table, and then you can get yourself a pain rating from that table, from that scale. When the baby is born, usually between 2 and 24 hours after birth, the baby requires its first bath. Like we said, thermoregulation is very, very important for the child. So when you bathe the child, you need to pay close attention to the temperature of the water. Usually it should be at least 36 degrees. And then um, the reason for the initial bath is to remove any blood and body fluids that could contaminate the healthcare workers. The amniotic fluid contains anything that the mother's blood contained, such as viruses, HIV, or anything else that the mother might be carrying. And then generally you use universal precautions when handling a baby, a newborn, and when birthing a baby. So when you are giving the baby its first bath, it is usually recommended to wait a minimum of 6 hours after birth to avoid interfering with bonding and the initial breastfeeding. So the initiation of breastfeeding. So depending, again, you need to follow your facility policy between 2 to 24 hours. The World Health Organization recommendation is wait 6 hours to allow the baby to have some skin-to-skin contact with the mom, bond, get that initial breastfeeding going and everything like that. A very important screening that's done on newborns is the congenital heart defect screening. This is very important. You will most likely have a question from this section on your test. The screening is conducted on a 24-hour-old infant. So the way the screening is conducted is that pulse oximeter probes are placed on the right hand and the right foot to obtain a reading of the oxygen saturation of the blood. If there's a difference of more than 3% between the hand and the foot, the test is considered positive, and the healthcare provider must be notified so that further testing can be ordered. So, for example, if you get a question and you're in a case study and the nurse places a pulse ox on the pulse oximeters on the baby's hand and foot and gets a difference of more than 3%, the nurse knows that this is a sign of what? It's a sign of congenital heart defect. The American Academy of Pediatrics recommends that parents do the following, and it is your responsibility to educate them on these notes before discharge. So with the concerning the umbilical cord stump, it is recommended that they keep the stump dry by folding the diaper below the stump of the umbilical cord so that it's exposed to air. Sponge bathe the baby until the cord falls off. Apply no antimicrobial cream to the stump. Apply no alcohol to the stump. Keep the cord clean. If the cord becomes soiled, clean with warm water and pat dry. Allow the dried cord to fall off on its own. Avoid pulling on the cord to dislodge it. Beware that when the cord falls off, a small amount of bleeding may be normal, just kind of like when the scab comes off or when you pick a scab off. Don't pick it off. Educate the parents not to touch it. Be aware that to report any signs of infection such as redness, swelling, or warmth around the umbilical cord. And then also we're going to instruct the parents of a circumcised newborn to do the following. For a few days, wrap the penis in a small amount of gauze with a dab of petroleum jelly to keep the gauze from sticking, to keep the penis from sticking to the diaper. Do not remove or try to wash off the yellow crust that forms. It is not a sign of infection. Give sponge baths until healing is complete and the ring falls off. Keep the penis clean and dry. Call the doctor if any of the following are noted. Discoloration of the penis, discoloration of the surgical site that includes pus, any discharge from the surgical site, a spot of blood in the diaper larger than 2 inches, a lack of urine, a fever greater than 37.8 or 100 degrees Fahrenheit, axillary, and if the baby cannot be calmed or soothed and is constantly crying or irritable, also take the baby back to the doctor. You're going to educate the patients on car safety. Is the nurse's responsibility to go downstairs and make sure, or go to the car and make sure that the car seat is put in and placed properly, that the parents know how to buckle the child in and use the five-point harness, educate the parents on how to use the bulb syringe, and different other different complications. Chapter 16, Newborn Nutrition and Hydration. Breastfeeding is the normal gold standard against which all research and recommendations for infant feeding should be measured. Women who receive education and family support are more likely to continue breastfeeding to 6 months or longer postpartum. Nurses play a crucial role in facilitating success with lactation. The mother makes her decision about whether or not to breastfeed before delivery in most cases. Therefore, her choice of feeding should be discussed with her starting the second trimester and throughout the pregnancy and postpartum. The CDC and WHO encourage exclusive breastfeeding to promote infant health and reduce mortality. The Academy of Breastfeeding Medicine recommends that all healthcare professionals promote breastfeeding early in prenatal care and recognize that breastfeeding is superior to bottle feeding. The promotion of breastfeeding by healthcare providers may help to increase support from families and employers, making it easier for the women to continue breastfeeding. Parents need to be provided with complete and current information on the benefits of breastfeeding and breastfeeding techniques. Because the baby is growing so rapidly immediately after birth and has such a high metabolism, the baby's caloric intake needs are extremely high, especially for the first 4 to 6 months of life. In this time, breast formula feeding can provide sufficient calories. The healthcare provider and pediatrician will measure the weight and length of the baby and put the information into the standardized growth grid to determine the adequacy of the infant's calorie intake. So for a term infant, the caloric needs is about 105 to 108 kilocalories per kilogram per day. A preterm infant is 110 to 120 kilocalories per kilogram per day. The estimated fluid requirements for a term infant is 140 to 160 mLs per kilogram per day. For a preterm infant, it's 60 to 80 mLs per kilogram per day. Now you might get questions giving you the weight of the baby, might be in pounds, might be in kilograms, and then asking you how much kilocalories per day does this infant need, or if the mother is feeding him this many times per day. How many calories does the infant need? Which is going to be a basic calculation that you guys might need to do. If you do get questions like this, you will get the requirements and conversions and everything in the questions. The question will tell you the requirement for this infant is 105 kilocalories per kilogram per day. 1 pound equals, 1 kilogram equals 2.2 pounds. You'll get all the information you need for your conversions and your calculations. It's important to know and to educate the mother of the child and the parents of the child that the newborn stomach is really, really small. So day one, it's only 5 to 7 mLs, and to see how small that is, when you flush an IV line, you're flushing 10 mLs. So not even 10 ml flush. Day 3 goes up to 22 to 27, and day 10 is 45 to 60. So it's important to educate the parents about feeding, how much a baby needs, how often to feed the baby, and that overfeeding will lead to regurgitation and the baby vomiting or bringing up the milk that they're feeding them. Not all mothers choose to breastfeed their babies. So even if you're enthusiastic about breastfeeding or you believe in breastfeeding, it's important to know as a nurse, you're going to educate the mother, but we're not going to make the mother feel bad about her choice to bottle feed or not to breastfeed. You should always educate the patient and support their decision regarding their feeding methods. When discussing breastfeeding choices, use open-ended questions like, what are your thoughts about breastfeeding? Tell me what you know about breastfeeding. What are your concerns about breastfeeding? And then we're going to try and kind of follow the policies that help promote breastfeeding, placing the newborn in direct skin-to-skin contact with the mother after delivery, assisting with latching, making sure the mom and baby are sleeping close to each other if possible, and then try to avoid supplements such as water and formula if possible. For the baby to receive the milk from the breast, the letdown reflex must occur. Suction on the nipple stimulates the pituitary gland to release prolactin to produce milk and oxytocin. Oxytocin causes the cells around the alveoli to squeeze the glands to push the milk into the ductules and into the ducts. The mother then notices the letdown reflex and a tingly or warm sensation in her breast. She may even notice the milk drip or spray during the letdown reflex. The letdown reflex can also be triggered by the mother hearing a baby's cry or thinking about her baby. As the baby suckles, the combination of the letdown reflex, compression of the areola, and the negative pressure created by the suction allows the milk to flow and to be delivered to the infant. It's important to educate the mother on the breastfeeding frequency and to educate the mother about what the letdown reflex is and what it does. There are different stages of human milk. Stage 1 is the colostrum, which is very important. It's the yellowish fluid that's present for the first 2 or 3 days. It contains high levels of protein and lower levels of carbohydrates and fats. It's high in immunoglobulins G and A, which protect the infant from infections, and has a laxative effect to promote passage of the meconium stool. So it's very, very important to try to educate the mother on why the baby needs the colostrum and why the baby should get the colostrum. Stage 2 is transitional milk. This is the stage from day 3 to about day 10. Contains increasing levels of carbohydrates and fat, again, to help the baby with its high metabolism rates and its need for carbohydrates and fat to keep to assist with that thermal regulation and its energy needs. And then stage 3 is the mature milk or the foremilk, which is the milk produced and stored in the breast between feedings. It has higher water content than hind milk. Hind milk is produced after several minutes of feeding and has a higher fat content and contributes to the feeding, the feeling of fullness and satisfaction for the baby. It is important to note that most drugs pass from the mother through the breast milk to the baby. If the mother requires medication while breastfeeding, the healthcare provider should check for risks to the baby before prescribing the medication and fully informing the mother of the risks. So there are some contraindications for breastfeeding. Um, Infants diagnosed with galactosemia. Galactosemia is a rare genetic metabolic disorder that makes it difficult for the infant to metabolize milk sugar. So breastfeeding the infant with galactosemia can damage their liver, kidneys, and brain. So if the baby is diagnosed with galactosemia, no breast milk at all. And then there's other contraindications such as a mother having HIV, if they're taking antivirals, if they have any kind of specific infections, so on and so forth. It's important for you as nurses to be able to assist in educating the mother and the techniques and the effectiveness of the breastfeeding. The mother should put the infant on the breast every 2.5 hours during the first 4 to 5 days after birth to assist with the creation of milk supply and also strengthen the baby's sucking reflex. Generally, it takes about 30 to 40 minutes of sucking for an infant to have a complete feed. If the infant falls asleep on the breast, the mother should be encouraged to take him or her off the breast and to change to the other breast and resume the feeding. It's encouraged for the mother to burp the baby or burp the child between breaths. And then also uh, to alternate the breaths at which each feeding begins. This helps stimulate the production of breast milk. And also, if possible, to avoid offering supplemental formula or water because some babies will suck on a bottle even if full of breast milk. Now, to make sure that the child has a correct latch on, you can observe the position of the mother. Is she comfortable with pillows or appropriate location and support? And then observe the position of the baby. Is the baby laying tummy to tummy with the mother? If not, you can reposition or educate the mother. Observe the position of the baby on baby's mouth on the areola. Usually the lips need to be 1 to 2 inches beyond the base of the nipple. Observe the infant's lower lip. It should not be folded. Observe the motion of the masseter muscle and listen for sounds of swallowing. And you should also be able to hear a clicking sound that indicates improper positioning if the baby's not positioned or latched on correctly. Observe the comfort level of the mother. Is she experiencing any nipple pain, any discomfort? If she has any nipple pain, she should take the infant off the breast and latch on again, or try the other nipple. If the mother is reporting sore nipples, you can educate the mother that sore nipples are a common occurrence but can be prevented or managed with the correct interventions. These interventions are making sure the infant has correct latch on every time it's placed on the breast. Try changing positions from sitting to side laying or a football hold, or try to move the infant's mouth to a different position on the breast. To pull the infant or detach the infant from the nipple, don't pull the nipple out of the infant's mouth or pull the infant away from the nipple. You need to gently insert the little finger between the breast and the infant's mouth to break that seal, and this will prevent pulling the infant off the nipple or pulling the nipple out of the infant's mouth and reduce the soreness. Also, change nursing pads often to avoid trapping moisture on the nipple. Expose the nipple to air to promote healing. Avoid harsh soaps on the breast. And then gently massage colostrum or breast milk into the nipple to soothe an irritated nipple. If the mother chooses to feed the baby formula, you need to know that the formula industry produces infant formulas modeled after breast milk. Formula, however, is not the best option. Cow's milk is not suitable for infants under 1 year of age. It's very high in protein. Um, it's high in fats that are difficult for the infant to digest. It's a very, very poor source of iron. Contains small amounts of vitamins C, E, and copper, and the sodium levels in cow's milk are very high. So cow's milk is not a very good option. There are, however, some advantages to formula. Nurses who work with low-income women and children should be aware of community resources available to support them. The Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC, is a government-funded program that provides supplemental nutritional foods such as infant cereal, baby foods, eggs, milk. The agency also provides screening for referrals to other health and welfare services. This is something that you can educate mothers on if they need it. If the mother is sick, has chronic illness, or is on medications that she can't appropriately breastfeed, formula could be an option. Another good thing about formula is that if the mother's not around, anyone can feed the infant. The father can help feed the infant, or any other person that's watching the baby. It's more comfortable to feed the baby formula in public, and certain foods and alcohol intake won't affect the baby. So if the mother wants to drink and not feed the baby breast milk that night, she can swap for formula. The patient's parents need to be educated if they are going to breastfeed the baby. and they're concerned about the safety of the tap water. The water should be sterilized before making formula. They can buy sterilized water to make their own. Water can also be checked for lead, nitrates, and bacteria. The best way to sterilize water is to let the cold water run until it is as cold as it gets. It may take at least 2 minutes. Bring the cold water to a boil and let it boil for 1 to 2 minutes, and then let the water cool before preparing the bottle. You need to educate parents that well water in rural agricultural areas can be contaminated with nitrates, which can be dangerous for the baby under 6 months of age. Nitrates can cause problems with the infant's blood oxygen levels. If the family does rely on well water and is limited on options, they should be cautioned to have their water evaluated for safety before using it for formula or purchase bottled water. Hello, everyone. So today we're going to be covering nursing care of newborns at risk and Chapter 17, and then nursing care of pediatric patients in the hospital setting, both acute and chronic. So when we have newborns in the hospital, we covered in the previous chapters some of the conditions that will place newborns at risk, such as premature labor. We talked about all the difficulties and complications that premature babies have, mainly respiratory issues. We're going to cover more in detail diabetes, hypertension. We'll talk about different kind of infections, diseases, and also we will go in future chapters more into detail about respiratory and cardiac issues. So one of the major complications that newborns will have, and we talked about this in the previous chapters, one of the most important complications that newborns will have are respiratory complications. So birth asphyxia, or also known as perinatal asphyxia, is a condition where the patient does not get enough oxygen to their brain, and it can potentially cause some serious complications and lifelong issues if it's not identified and treated immediately. So this happens when during the birth process, if the mother doesn't get enough oxygen during labor, or the mother was diagnosed during pregnancy with preeclampsia and has high blood pressure or low blood pressure during labor, if the placenta separates from the uterus too quickly and causes a loss in oxygen, if the umbilical cord wraps around the baby's neck or the infant's neck and causes suffocation and asphyxiation, if the fetus or the newborn is anemic and doesn't have enough red blood cells. Again, why did we say it's important for newborns and infants to have adequate red blood cells and adequate circulation? Because red blood cells carry oxygen around, so they need to get that oxygen circulated throughout their body. If their airway is physically blocked by any physical means, and or if the labor itself becomes too long and too complicated, all of these can cause issues with oxygenation and asphyxia, which, if not treated or not stopped, prevented, can cause long-term. So respiratory distress is one of the most common complications with neonates. So it can be caused by asphyxia, lack of surfactant in the lungs, fluid in the lungs, physical obstructions, or like we said, if the umbilical cord is wrapped around the neck and suffocating the baby, meconium aspiration, which we're going to cover, and cold stress or thermoregulation. That's why we mentioned that thermoregulation is so important. So as nurses, you should be able to identify the signs and symptoms of respiratory distress um, and be able to perform interventions or initiate the care that you need to. So provide, for example, provide oxygenation. You're going to want to improve gas exchange and provide further complications. Study the pathophysiology of um, respiratory distress syndrome and how it affects the body. We're going to cover the signs and symptoms, which is the most important thing that you as nurses need to be able to identify. So the signs and symptoms of RDS or respiratory distress syndrome is tachypnea, dyspnea, grunting with expiration, um, nasal flaring, using intercostal muscles or abdominal retractions like we mentioned, and of course cyanosis. The medical management for a patient with RDS is um, antenatal corticosteroids. You're going to transfer the patient to a NICU unit. They'll get surfactant therapy, oxygen therapy, CPAP therapy. They'll be placed on a CPAP if needed. If their condition warrants, if they're not doing very well, then they will need to be intubated and have mechanical ventilation. The next complication of a newborn is TTN, or transient tachypnea of the newborn. It is a common condition in infants where tachypnea, with which tachypnea, increased oxygen needs, and mild respiratory distress occur. TTN usually occurs in infants sedated from maternal pain medication during labor, prolonged labor, and babies born with cesarean section, via cesarean section. Usually it is resolved with proper care and management. It resolves within 3 to 5 days. Here's another thing that we mentioned earlier, meconium aspiration syndrome. So what is meconium? Meconium is that first bowel movement or the first stool that the fetus has. Meconium aspiration syndrome is exactly what it sounds like. It's when the fetus is inside the uterus, it becomes distressed, and it for any reason, whether it's cord compression, infection, or any other stressor, the fetus passes meconium into the amniotic fluid, and then because the fetus is floating in the amniotic fluid, they'll aspirate on that meconium. So meconium aspiration, it usually affects term and post-term newborns. Usually is not usually seen in preterm babies, and when the baby or the newborn aspirates meconium, it blocks their bronchioles, and it causes poor oxygenation, aspiration pneumonia, and possible pneumothorax or collapsed lung. And this is something that is, once the baby is born, is a medical emergency, and the baby will be required to be moved to a NICU unit. So the next condition that we're going to cover is the persistent pulmonary hypertension, or PPHN. You can read the pathophysiology of this complication in the book in detail. The one most important thing that you need to remember or know is that it's caused because the fetal circulation rates persist or remain the same as it was in the uterus after birth. So the common causes of PPHN are prenatal asphyxia, RDS or respiratory distress syndrome, neonatal sepsis or any kind of infection, and congenital heart and lung defects. What you need to know as nurses and what you need to identify are the signs and symptoms. The signs and symptoms are very similar to respiratory distress syndrome. Why? Again, because they have circulatory issues and they can't circulate that oxygenated blood, so they're going to have cyanosis. But cyanosis that doesn't improve with oxygen because they can't circulate that oxygenated blood. They'll go possibly go into shock, have really low blood pressures and high heart rates, and with these infants you usually be able to hear a very clear heart murmur. We spoke previously about the importance of thermoregulation and how quickly newborns lose their body temperature and how important it is to keep them warm. The risk of cold stress is greatest right after birth. That's when they have a lot of heat loss, and that's when you need to keep them warm. And then usually if you have conditions where babies are born outside of a hospital or healthcare setting because of emergencies or anything else, that those babies are at greater risk for cold stress. Please see table number 17.3, identifying and treating newborn cold stress. It has 4 columns, goes over different aspects of who's at risk, what is a newborn's physiological response, and the signs and symptoms of it. So the main signs and symptoms are that you need to be aware of are temperatures below 36.3 Celsius or 977, a very weak or faint cry, respirations that become slow and shallow, jitters from low blood sugar, and lethargy or lack of response, and respiratory distress. Okay, neonatal hypoglycemia. So if you go in your book, if you go to table 17.4, these tables are very good. They have all the information condensed into a table, so use these tables to study. So for neonatal hypoglycemia, I think we touched on this in the previous chapter. So it's blood sugar or glucose levels lower than 30. So this is the most common metabolic problem that can affect both healthy and preterm, postterm, ill-appearing infants. Long-term complications from frequent and prolonged hypoglycemia are neurological damage, intellectual disability, developmental delays, personality disorders, decreased head size, seizures. As a nurse, you need to make sure that you're checking the blood sugars with heel stick blood samples. For newborns, they always use heel sticks. Always check the blood sugars immediately after birth. Specifically for larger babies or smaller babies. Babies who are larger or smaller with their birth weight. So you want to make sure that you're covering. There you're are their some blood glucose, checking their blood glucose soft levels. Tissue injuries. So moving on to care of newborns with birth injuries, such as cephalohematoma or physical injuries that can occur as a result of abrasion or lacerations from instrumental deliveries. So these are injuries that can be prevented. Sometimes they can. Sometimes trauma. So it can be, if you have macrosomia, you need to get that baby out. You need to get them out. Cephalopelvic brachial plexus injury is or very rapid delivery, an injury that
occurs from the increase in infants' neck and shoulder ankle,
such as breech,
large fetal head. These are all injuries that are caused by complications during birth or complications during delivery.
which are the nerves that are in your neck area and then branch off to control movement in your shoulders and arms. So usually it's very, very uncommon, but it does happen usually in much larger babies that have a much higher birth weight, or babies who have a longer delivery or are a breech at birth. Baby
in
with brachial plexus under the axilla. Sorry, moved on to the next slide.
So we
went over
jaundice
previously, so we're just
or
going to
jaundice
we
we
covered
is when the
previous
serum bilirubin
chapters.
levels rise
Touch on it
excessively
here real quick
and require treatment. So
to accelerate the removal of blood before complications occur.
there is
In your book,
when
if you
serum
go to table
bilirubins are
17,
elevated
that's
5,
when you start seeing changes
you can
in the
see
skin. Most common
the lab
manifestations
test
are
for
the yellow
newborns
color
with
in the skin
jaundice
and the yellow color in
and
the eyes and the sclera.
and what each
If
lab
it's
test
not
measures.
treated
So,
is when it becomes
really dangerous
table 7
and can cause neurotoxicity or kernicterus.
Usually the yellowing in the skin will start to spread down the body as the bilirubin levels rise. So what's important to note here is to prevent or manage this, you need to start early frequent feedings. You need to get that baby to start latching on, whether they're breastfed or if they are formula. You need to get them to start feeding early. Monitor them. You're going to have phototherapy. Phototherapy is when you put the Billy baby under a light. So when total serum bilirubin levels are at or above 15 in infants for 25 to 48 hours old, 18 in infants 49 to 72 hours old, and 20 in infants 72 hours or older. So the phototherapy you use to help the body get rid of extra bilirubin. In the book, I think that it covers how phototherapy actually works and helps, but the pathophysiology of it, you don't need to know that. For your purposes as nurses, you just need to know that phototherapy and light therapy are used to help get rid of that extra bilirubin. Like we said, if it gets to the point where it turns into neurotoxicity and starts causing issues, the baby will be admitted to NICU and may even need blood exchange transfusion to prevent or treat that kernicterus. If you bilirubin levels don't drop with feeding or phototherapy, that neurotoxicity and that kernicterus can be really dangerous and cause permanent damage. So neonatal sepsis is a blood infection that's caused by different kinds of bacteria. Basically, their body comes out of a sterile environment.
Group B strep,
sterile. Everything in their body is basically
E. coli,
sterile. So
or herpes.
any kind of bacteria or foreign organism that they're exposed to, especially foreign organisms during vaginal delivery or vaginal labor from contaminated hospital personnel or any kind of infection that the mother would have, any kind of if the equipment used is not sterile or properly taken care of, all these factors can cause infections for the newborn. Their bodies are very, very susceptible to infection. They have basically no immune response. Their immune system is very immature and unable to fight against any kind of infection. Okay.
on, you're going to, just as you would with any other infectious disease, or if you were taking care of any other patient that had HIV, you have to be very, very cautious when you have the mom and the baby. So you're going to maintain strict standard precautions. Pregnant always mother with gloves. HIV, the mother or the baby without gloves, who's giving birth to a baby, anybody, including anyone else, including the baby, the family handling the baby, HIV not being transmitted to the baby, should be advised that you need to wear gloves without interventions. If you notice any sort of abnormality, respiratory or otherwise, you need to inform the healthcare provider immediately. Prenatal care, and like we said, that antiviral medication, antiviral therapy by their provider. I don't know if I'm saying that correctly. ZDV, and then is usually or if you have Nevirapine, mother NVP are the two medications that are as soon as the baby is born, you want to test that baby. You need to make sure that you're HIV administering them as prescribed by the provider. And then also you want to start, and then also you're going to antiviral therapy. Advise the mother not to breastfeed for the infant. That could, if the patient is not HIV positive, that could transmit through breast milk to the patient and cause complications later. Provide opportunity for parents to hold the bond with the newborn just like you would any other baby. For these patients, especially the ones going to a NICU, you want to keep an extra eye out and make sure you're educating the family and letting them know everything that's going on with their baby. Never leave any questions unanswered, or leave any blank spaces that could cause them anxiety. So, as we mentioned, when you have patients, newborns that are at risk or have complications, it causes a lot of emotions and stuff for the family. And like we said, we're going to focus on family-centered care with our newborns and our pediatric patients. So, especially if the patient has to be transferred to a NICU, there's a lot of emotions and fear going on. You might have the family get angry towards the healthcare team. The family might feel guilty and think it's their fault. There's a lot of different things going on, so you just want to be aware of everything and make sure you're addressing everything appropriately.